All right, week 1 respiratory. There we go. Alterations in pulmonary function and vasculature. So there is a difference between ventilation and respiration. For ventilation, this is literally just the mechanical moving of air in and out of the lungs. In contrast, respiration is the actual exchanging of gases that occurs at the level of either the alveoli or at the tissues. When it comes to ventilation, we can have a few different measurements we can include. So we have 4 different lung volumes that we can measure and 4 different lung capacities. So we have these 4 different lung volumes and the 4 different capacities. The ones that are highlighted are really the ones that we ever really need to be worried about. I think that goes for Rachel as well. Tidal volume, this is simply the amount of air that we can breathe in during a normal breath. So you take a breath while you're relaxing, normally it's around 500 milliliters. Residual volume, this is going to be the volume that is left in the lungs after you fully breathe out. You breathe out as hard as you possibly can. Whatever is left in the lungs is your residual volume. This is kind of also the volume that helps to ensure that our alveoli don't collapse, among other things. Vital capacity, this is going to be the total amount that can be exhaled during a maximal expiration. So you take your deepest breath in possible, how much you can blow out at maximum will then be your vital capacity. Total lung capacity is the total amount of gas contained in the lungs at maximal inspiration. So we're going to be talking about basically a combination of vital capacity plus residual volume. So you take a full deep breath in, it's the amount of air that you can have, the volume in your lungs from taking that deep breath in, plus along with that residual volume, the amount that you have that never really kind of leaves your lungs. So hypoventilation, this is ventilation that is too slow compared to what your body needs, and we don't have enough movement to allow for O2 to go to the tissues or remove CO2. We're going to end up with increased CO2 or hypercapnia. That's a term for increased CO2. And by not having enough ventilation, we're also going to have hypoxemia, which the definition of hypoxemia is low levels of oxygen specifically in the blood. Emia means in the blood. So this can be due to sedative drugs that are knocking out our respiratory drive, obesity, being that we have too much weight on our system, leading to low levels of ventilation. Myasthenia gravis is an autoimmune condition that affects our respiratory drive, obstructive sleep apnea, all these things. Hyperventilation is going to be increased volume of air entering the alveoli. We're going to have, because we're hyperventilating, we're breathing more than we need to compared to what the tissues need for oxygen. And so we're going to end up having this decrease in PaCO2 or hypocapnia. We can also have potentially hypoxia, which hypoxia is simply the state of having low levels of blood. It doesn't have to be specifically in the tissues, or I'm sorry, the blood. This could be low levels of tissue anywhere. So cyanosis could be a sign of hypoxia. What's interesting is you would think that hyperventilation would lead to, or would treat hypoxia, and we would have normal to high levels of oxygen in the body. But there's a couple of reasons why. First is we have CO2 being blown off. That can lead to alkalosis, since CO2 helps to maintain acidosis, or that range. You blow it off and it will become more alkalotic. And being alkalotic can promote oxygen to have a stronger affinity for hemoglobin, making it more difficult for it to dissociate at the level of the tissues. So we may have enough saturation in the blood itself, but we may actually become hypoxic at the level of the tissues because we're not actually exchanging gases down there. In addition to that, hyperventilation can actually potentially be too quick of a movement of air through our lungs to allow enough time for gas exchange to occur at the level of the alveoli. So pain and anxiety are common for leading to hyperventilation. We can have obstructive and restrictive lung diseases, which are what we're covering in this lecture and the next lecture. Sepsis can lead to hyperventilation due to high levels of lactic acid in the body, and then brainstem injury affecting the respiratory drive controller in the first place. Again, hypoxemia is the deficient blood level of oxygen, low levels of PaO2, and low levels of hemoglobin saturation. So for ventilation perfusion matching, this is something that you're going to see a bit. V is going to stand for ventilation. For whatever reason, they chose Q to represent perfusion, and we get a ratio of these two, which equals V/Q. We want them to match. That means we have both adequate blood or a volume of air in the alveoli, and we have enough blood flow to balance out the need for oxygen and to get rid of CO2. When we have an imbalance, they can mean sort of different things. So a high VQ mismatch, the high or low is indicating the ventilation aspect. So a high VQ mismatch means we have high levels of ventilation compared to our levels of perfusion. So either that means we're like really ventilating a lot, hyperventilating, or we are underperfusing if we have a high VQ mismatch. So this could be a person who is having a panic attack. If the perfusion is correct and the ventilations are high. Or on the other end of the spectrum, if the ventilations are normal, but we don't have enough perfusion, that could indicate potentially a pulmonary embolism. So we have our pulmonary vein here, which leads up to capillaries. These right here are our airways and alveoli. So with a high VQ, we have blood flow to some, but it's kind of shunted in certain areas. Not shunted, but there's a blockage because there's perhaps a pulmonary embolism right here. But we have enough of air movement through the alveoli and the airways, whereas with a low VQ mismatch. So these people, we're not going to really be able to change much the perfusion. Once we get to a certain point, it's just that's at maximum. But we have, in relation to perfusion, a low level of ventilation. So these are going to be people who are having, for example, COPD or asthma. For whatever reason, there's some reason for why the airways themselves are restricted or obstructive. They're not able to allow enough air movement through to allow for ventilation to occur and for gas exchange to occur. These are going to be these conditions are going to be responsive to treatment with oxygen because while we may not be able to, we will be able to use certain other drugs to try to open up these airways, but by increasing the proportion of O2 in the air that we're breathing in, we can allow for more gas exchange to occur because, I mean, oxygen in the atmosphere is only 21%. So if we're bumping that up to 60%, 80%, then we'll have a better ability at the short term, until we can fix the underlying problem, to have adequate gas exchange to occur. For a shunt, which is what we have down here, we simply we don't have airflow. We've got plenty of blood flow going on compared to, say, this pulmonary embolism here. But there's a complete lack of airflow through this because, for example, in atelectasis, this is where we're going to have, in small parts of the lungs, a complete breakdown or collapsing of the alveoli. So we're not going to have any benefit from giving them O2 because if there's no movement of air at all, then O2 can't get in there and better oxygenate that area of the alveoli. So a pulmonary embolus is something that we can lead to a high VQ mismatch. It can be anything from blood clots or a fat emboli. It could be an air emboli, which don't let the movies fool you. The air emboli idea requires like 100 milliliters of oxygen. You can't just get a little bubble and have it form a deadly air emboli. You have to have a tremendous amount of oxygen or air to actually cause a air emboli. 90% of the thromboemboli originate in the deep veins of the lower extremities. So that's important to remember. So like DVTs. That's where we're going to get 90% of our thromboemboli originating from. So we have someone who is on a long plane ride, or they had a car ride, or perhaps they were lying in bed for too long without movement, without using proper equipment after surgery. They developed DVT. We can promote a DVT or any kind of pulmonary emboli from venous stasis anytime we don't have enough blood movement at all, hypercoagulability, and damage to the vessel. We may have multiple of these factors working together, or we may just have one or two. So common risk factors: DVT, immobility, trauma. So a person's got surgery and they're staying in bed, not moving around enough after they have surgery. Pregnancy, mostly due to hormones occurring during pregnancy. Cancer, heart failure, smoking. So the thrombus, for example, may be dislodged from a DVT by trauma or by exercise or by changes in blood flow, travels up to the heart, and the first place it's going to go to from being in the venous system is going to be the lungs, because it goes through the heart on the right side, goes out or comes in the vena cava, goes to the right atrium, right ventricle, out the pulmonary arteries, and goes straight to the lungs. And so the lungs kind of work as these giant blood clot filters. How serious or significant the PE is depends entirely on the size of the thrombus. If we're talking about like a tiny thrombus, then we may only be experiencing some chest tightness and maybe some annoyance. If it's huge, then they could die. We can experience restlessness, anxiety, sudden dyspnea, tachycardia, and tachypnea, because they're trying to compensate for lack of blood flow and oxygenation. And then a lot of people may mistake this as being an MI or acute coronary syndrome. It's important to make sure that we are looking at, whether or not this is actually an MI. But one way to sort of think about whether this actually is an MI or a PE is whether, or pneumonia, there's a bunch of other reasons. People who are experiencing an MI generally don't have pain on inspiration or that worsens with inspiration. Normally it's this consistent pain, however they describe it, regardless of whatever they do. Whereas with a PE, they're going to experience chest pain that is worse on inspiration. Diagnosis of a PE occurs primarily via a ventilation perfusion scan or a VQ scan. The gold standard now is a specialized CT scan, but that's not very available. So VQ scanning is still something we're going to do. We're going to look at ABGs to determine whether they are acidotic, alkalotic, and the history of what may have led to this PE. So if we know that they just came off of a 12-hour flight, we're thinking, hey, we may want to look at the legs. Well, we're going to want to look at the legs anyway. But we're going to think, oh, yeah, this person has a much more significant chance of developing a DVT and thus then a PE. So we're going to want to treat the underlying problems, such as that DVT, which we may use a umbrella filter or embolectomy to prevent it from getting worse. So this is what that umbrella filter kind of looks like. It's going to hold on to that clot and prevent it from flowing back into creating another PE. May give some thrombolytics or something or blood thinners to try to break this down safely while it's caught in this umbrella. We're also going to teach and promote prevention measures, both to prevent the current PE or clot situation from getting worse, and to allow for the patient to, on their own in the future, avoid getting another PE. So we want to educate and promote avoiding prolonged bed rest. So if they have to be in bed for a long time period, then encourage them to at least start flexing their muscles, their legs, moving stuff around, allow for and promote blood flow. Promote active range of motion, use compression stockings, which can have pneumatic compression on them themselves, or find some other way of allowing compression. And then using medications such as maybe some blood thinners. If the PE is confirmed, we may give them a heparin drip or thrombolytics, and then oxygen to try to promote enough oxygenation around to the other healthy areas that are not affected by the PE, and bed rest. The bed rest will be monitored and balanced with activity as well. We're going to skip this case study. In pediatrics and geriatrics, we're going to see differences in how they breathe and ventilate and respirate compared to normal healthy adults. In pediatrics, we're going to have all of these respiratory differences are going to lead to an increased level of worker breathing and in the respiratory rate. So pediatrics have increase in mucus. They also have a decreased size of the anatomy. So we have more secretions in a smaller tube for pediatrics. That's going to lead to obstruction or a greater chance of obstruction and inspiratory resistance. So that makes it that much more likely for them to be experiencing a choking hazard. And it also potentially leads to a greater risk of infection because we have that much less, we have that much more mucus to get out through that much smaller of an airway, allows for things to kind of sit there longer. They also have very flexible ribs with less elastic recoil, which doesn't really do well for allowing or promoting them to breathe well using their intercostal muscles. That means we're going to have kids using diaphragmatic and abdominal breathing as their primary muscular control of breathing. They also, compared to adults, have a higher positioning of their upper airway structures, and they're narrowed still also. They have the decreased size of those structures. So we're going to have an increased risk of aspiration and infection because of the higher positioning, increased mucus, and decreased size of the anatomy. For geriatrics, we have a decrease compared to pediatrics. They have more elastic recoil compared to adults. Geriatrics have less elastic recoil compared to adults, and they have a stiffer chest wall, which is going to make it more difficult for them to breathe. They have to rely less on the intercostal muscles and rely more on the accessory muscle use and the diaphragm and abdominal muscles. Unfortunately, the diaphragm, intercostal muscles, and accessory muscles decrease in how strong they are over time. So they're not going to be very effective, for example, at what we really need them to be good at, which is cough effectiveness. That's how we get a lot of our junk out of our lungs and how we promote getting bacteria out of our system or fungi or viruses using that mucus escalator. We also have in geriatrics an increase in mucus production similar to children. This is going to lead to a low VQ mismatch because we are affecting the flow of air, not the flow of perfusion or blood flow, because of this mucus. That's going to lead to a decrease in gas exchange and a decrease in cough effectiveness because the more mucus we have, it's a little confusing the way that's written. So the more mucus we have, the more we're going to need to cough because we have all this mucus. All that mucus will lead to a decreased VQ mismatch or a low VQ mismatch, which will lead to a decrease in gas exchange because we simply don't have enough gas in the first place. And then because we also have a decreased level of cough effectiveness due to the impact to the chest wall and the muscles attached to the chest wall, we're going to have that mucus hanging out there also. I guess you could actually say the cough effectiveness may lead to an increase in mucus because we can't get it out in the first place. We're also going to have alveolar enlargement over time, which may lead to increased residual volume. So we don't actually have as much volume to work with in the lungs, as much surface area to work with for gas exchange, leading to, again, a low VQ mismatch, because this won't be affecting necessarily the perfusion. With a lack of alveolar surface area, we may end up with less vasculature, but overall the problem is that we have a low VQ mismatch because we don't have enough air surface area to allow for gas exchange. We also, over time, may have a decrease in pulmonary artery blood flow for a number of reasons, such as valvular problems in the heart failure, multiple different problems. And that may lead then to even further decreasing in blood oxygen saturation. All of these differences that occur between geriatric and pediatric respiratory systems compared to a normal adult lead to an increased work of breathing and an increase in respiratory rate. All right, so pulmonary disorders can be divided up into generally either obstructive pulmonary problems or restrictive pulmonary problems. Restrictive pulmonary problems have to do with a decreased ability for the chest wall to expand. It's restricting the expansion of the chest wall. Obstructive pulmonary disorders happen from inside the lungs and have an issue with obstructing the lungs from being able to fully allow air through. So there's going to be a resistance to airflow. We can have an obstructive pulmonary disorder from conditions to the wall of the lumen itself, such as in asthma or bronchitis, a loss of lung parenchyma, simply like the alveoli themselves. So the primary tissue associated with that organ is parenchyma. Or we can have issues to the airway lumens, the inside hulls of the tubes in the airways, such as in cystic fibrosis or aspiration of a foreign body. So acute bronchitis is kind of you can kind of think of this as your typical chest cold. There's some kind of an acute inflammation of the trachea and the bronchi, so the larger tubes. This is characterized by a cough with or without sputum production, lasts at least 5 days, and generally resolves on its own within 1 to 3 weeks. This is normally caused by a viral infection such as influenza, rhinovirus, or RSV. We can have bacterial etiologies. It can be due to heat in the lungs themselves or the smoke that's associated with the heat, or maybe some other form of irritant and chemicals. It can be due to an allergic reaction or asthma. But in general, what we have is we have a immune system response. And we have the inflammatory cells infiltrate the area in the bronchi or the trachea. We lead to capillary dilation, which leads to the airways narrowing and becoming more swollen from fluid exudation. So we have all the capillaries are becoming leaky, and they're allowing, as part of the immune response, all this fluid and mucus buildup to occur inside the lungs, inside the bronchi and trachea. So we're going to have an increase then of mucus production, and we're going to have a decrease in ciliary functioning, which will lead to the mucus kind of hanging out in there as well a little bit longer as part of that immune response. So that'll all end up leading to a loss of portions of that ciliated epithelium, which lines the inside of the bronchi and trachea. So this really is kind of a self-limiting issue, and it's really just revolves around inflammation, and immune response to something in the lungs. Normally it's going to be viral, but it can be a bunch of other things also. Um, and the symptoms are usually mild and self-limiting. You don't normally need to take something. You may have a cough or low-grade fever, maybe some substernal chest discomfort, sore throat, post-nasal drip, or fatigue. Your typical chest cold, maybe flu. Um, Diagnosis is generally based off of the clinical presentation, being a cough, and we may do a chest x-ray to ensure that it's not pneumonia if we have a fever and we have a bunch of sputum production, because pneumonia is going to require antibiotics if it's bacterial. So, but we're not really going to want to use antibiotics unless we absolutely need to for acute bronchitis. If it's viral, you wait it out. If it's bacterial, depending on the severity of the illness, we may give antibiotic therapy, but we want to make sure we're also not producing superbugs. If we have a painful cough, we may give codeine for cough suppression. We're going to educate them on increasing fluid intake because the body needs extra fluids and extra nutrients during this to recover. And we want to avoid smoking since that's just going to make everything worse. All right, so that's acute bronchitis. Now we have COPD, or chronic obstructive pulmonary disorder, which is divided up into two different specific conditions. We have the chronic bronchitis and we have emphysema. They both are classified as chronic obstructive pulmonary disorder because they have a lot of similarities, but they also have several distinct differences. COPD in general is a slowly progressive disease that affects the airway, pulmonary parenchyma, or both. And I've heard people call it parenchyma or parenchyma. I don't know. It is a chronic condition, meaning it is persistent and is irreversible once it starts. People can kind of control it. There are things we can do to better control it, but it is chronic. It is irreversible. Generally begins in middle age, affects 27 million people, and it's generally preventable in some way. It's not like this congenital or genetic disorder that people are going to develop. Some people have a genetic predisposition towards it, but generally it's from exposure. The primary exposure is cigarette smoking or repeated airway infections. Maybe through asthma, but that's not as common. Cigarette smoking and infections are really our number one things. With chronic bronchitis, this is type B, B for bronchitis, and it's our blue bloater. What they mean by that, and that's not really a very PC term we can use for it, but blue bloater is a classic term because these people end up becoming somewhat cyanotic from a lack of oxygen. Bloater because they're generally larger people, potentially from airway trapping or oxygen trapping, or just also from kind of generally being overweight. Other etiologies that we haven't touched are inhalation irritants. Socioeconomic status is a risk factor for chronic bronchitis because if you have low SES and you're living near an industrial area with lots of pollutants in the air, you're at higher risk for developing chronic bronchitis compared to someone who is better off living in a area of a city or region that doesn't have a whole bunch of industrial development nearby. In chronic bronchitis, the pathogenesis is that we have some immune response and inflammation. This is not like one of those acute bronchitis things where you have a single exposure and you have chronic bronchitis. This is like over and over and over, we are having an immune response. And over and over and over, we have the increased production of goblet cells because there's crap in our lungs that our lungs are like, get this crap out of here. We don't want this. It's making our job harder. Trap this stuff and get it out via that mucus escalator. All of that's going on chronically. And eventually, we develop chronic inflammation of bronchial mucosa. The big thing being that we develop scarring from this inflammation and fibrosis as part of this remodeling of the airways in response to this constant stress and trauma. Doing that prevents then proper oxygenation. We also have hyperplasia of the bronchial mucus glands, which leads to this massive production of mucus. This extremely productive mucus can lead eventually to mucus plugs that block then the airway. We also have increase in bronchial wall thickness because of the hyperplasia of the mucus glands, potentially the hyperplasia or hypertrophying of the muscles around the airways. This is going to lead to resistance in the airways, increasing the work of breathing and O2 demands, because we're having to work that much harder to just even get air into our lungs in the first place. We're going to end up with a low VQ mismatch and have hypoxemia as well as hypercapnia because we're not able to even get oxygen in or CO2 out because we have all this gunk, this mucus, as well as the scarring and fibrosis inside the lungs that make it really difficult to get anything in or out. The alveoli normally are empty, and they begin to fill slowly, leading to a decrease in arterial O2. I'm not following that exactly. So, I mean, they're probably going to fill kind of slowly via the mucus production that we have and a lack of cilia that develops over time from this chronic inflammation and replacement of the endothelium with scarring and fibrosis. All of that's going to lead to an inadequate level of oxygenation within the alveoli and thus a decrease in arterial O2. All of this effort, all of this work of breathing and destruction of available surface area in the lungs can lead to pulmonary hypertension because we're going to be having pulmonary artery resistance within from just, how do I explain this? With all this gunk inside, there's just a lot more difficulty getting the pulmonary arteries to go through because there's increased pressure and inflammation inside the lungs. It's more complicated than that, but just understand that pulmonary artery resistance and hypertension occurs whenever we have pulmonary problems. And that can always lead then to right-sided heart failure because we have so much resistance that right ventricle is having to work that much harder to pump blood through. Cor pulmonale. So we have here other forms of restriction or obstruction. We have like pulmonary vasoconstriction. We have fibrosis here, buildup of scar tissue and fibrotic tissue. I guess this is a thrombosis in here, hypertrophy. Okay. So again, continuing on with the pathogenesis, we're also going to have destruction of the bronchial walls because of all this inflammation. Some people may result in bronchiectasis. Come on, where are you? Bronchiectasis. Bronchiectasis is dilation of the bronchi from constant, continuous inflammation. Not everyone with COPD, chronic bronchitis, develops bronchiectasis. Some do. Some people also can have dilated sac pools of secretions that do not clear, and when we aren't able to clear all of that mucus production, that's a major risk for infection, especially if they then spread to adjacent lung fields or other areas. Sometimes, I guess, they can lead to the brain. I hadn't learned that before. This is kind of what's supposed to be these two pictures here and here are like stereotypical chronic bronchitis patients. A lot of times they end up with some swelling in the abdomen. They may develop right-sided heart failure, leading to ascites, maybe some swelling in the ankles and legs because of that right-sided heart failure. Um, Typically overweight, they have an increased risk of infections because of a more difficult time getting mucus up out of their lungs. Anytime they start moving around, they're going to suddenly become dyspneic. They're going to have tremendous amounts of sputum because they have so much mucus from whatever was irritating their lungs and led to the chronic bronchitis in the first place. They have a very chronic cough that is more severe in the mornings because they have less of a cough throughout the night. And so all this crap kind of develops in their lungs. They wake up. Suddenly now they just got to get all that stuff out because they're more aware of it. They may have excess body fluids, edema, because of the right-sided heart failure that can occur with COPD. And then a late sign that they may experience is cyanosis from just simply not having enough oxygen. People with COPD regularly will have oxygen saturations in the upper 80s, mid 80s, because they're having to rely instead, they have so much buildup of CO2, and CO2 in their body is the prime driver for ventilating, for breathing. The chemoreceptors that detect CO2 tell the medulla, hey, amp your breathing up, we got to knock out the CO2. Eventually, the body kind of adapts to that, and we end up relying instead on O2 levels, which intrinsically have a much lower set rate or set point for when they tell the medulla to start breathing or to signal the lungs to start breathing. So they kind of just sit there at around the upper 80s, like 88%. And we got to be very careful then in how much oxygen we give them via normal or nasal cannula or anything else. Because if we give too much, then we may knock out their breathing, their drive to breathe altogether. We diagnose chronic bronchitis based off the classic symptoms that they have. We may do a chest x-ray to confirm that they don't have anything else going on. We'll do pulmonary function tests, breathing into a spirometer, arterial blood gases, and EKG to rule out other issues. Treatment goals, we want to overall block the progression of the disease because we can't fix this disease at this point. We want to do our best to return them to optimal respiratory function and promoting adequate ADLs and IADLs because that way they can kind of progress or prevent the progression of the disease. We want to really push them to give up smoking or being around whatever irritants may get into the lungs. We're going to educate them on bronchodilator use like albuterol or Atrovent, which are more, we'll get into those, and maybe steroids or some other anti-inflammatory therapy. We want to educate them on alternate rest and physical reconditioning, so talk to them about how they need to get into better shape with their lungs because the more they use the lungs and promote adequate flow, the better the lungs are going to be. We want to tell them to really amp up the hydration so that we can kind of thin out that mucus in their lungs and allow it to be coughed up. And then we got to make sure, this is huge, that they get their vaccinations for influenza and pneumococcal since they are at very high risk of developing illness. So emphysema is our other kind of COPD. These are our pink puffers. Again, not very PC term. And it's type A COPD. Once again, it's irreversible, but instead of chronic bronchitis, where the issue is hypersecretion of bronchial mucus due to irritants and inflammation in the bronchi, these have irreversible destructive changes of the alveolar walls. So this is normal. This is a healthy bundle of alveoli. And in people with emphysema, we have sort of the breakdown of the walls connecting between alveoli. And instead of having all of this great high levels of surface area in the alveoli, we end up with much less surface area, leading to lower levels of oxygenation in the blood. This can occur from smoking, the highest reason for and the most likely cause for COPD, emphysema, Air pollution, low SES, being around different industrial areas or being in an occupation that promotes having you around these areas. People also can have alpha antitrypsin deficiency, which is a genetic issue um, where the lack of having alpha 1 antitrypsin or AAT helps. All right, so AAT itself regulates enzymes that destroy lung tissue. So having AAT helps to regulate that. Not having AAT will sort of allow these enzymes to destroy portions of lung tissue. So if we see someone who has emphysema at a very young age, and perhaps they don't even have a exposure history, then we're going to be thinking about checking to see if they have an alpha 1 antitrypsin deficiency, which is also passed down through hereditary means. And emphysema and chronic bronchitis can sometimes go hand in hand, and people can have both of them together. So again, this starts with inflammation, except it affects the alveolar wall damages, or alveolar wall, as opposed to the bronchi themselves, or bronchioles. Or we can have alpha antitrypsin affected instead. We have a reduction then in the pulmonary capillary bed and a loss of elastic tissue in the lungs. And elastic tissue in the lungs around each individual alveoli actually is part of what helps to allow us to passively exhale, because they're constrictive and they promote the lungs to exhale. When we have someone with emphysema, they actually have to forcefully exhale because they no longer have as much of the elastic material in their lungs. We also have air trapping in those distal alveoli, and the loss of alveolar wall and that air trapping can lead to bullae formation, which are air sacs like this right here. These are bullae. They are either air or fluid-filled sacs in the lungs. Typically, it's air trapping in the lungs, but you can have either. And are useless. They don't allow for any air travel whatsoever. Some of the clinical manifestations that we can have with emphysema: exertional dyspnea that gets worse over time. Generally, as you can see over here, they are very thin because they have such an increase in respiratory effort that they lead to a dramatic increase in caloric use or expenditure, because they're having to not only work with every breath to breathe in, they have to work to get every breath out. We're going to see very strong accessory muscle use, this pursed-lipped breathing here because they're trying to increase the effort of blowing air out. They may have a cough, they may not. It's not like chronic bronchitis where we have this increase in mucus production. We also can have this digital clubbing, which is the fingernail clubbing, which comes from having, I think it comes from high levels of CO2 in the body. And then we can also have this barrel chest. It's not as prominent on this guy here, but it comes from the hypertrophy of the musculature used in respiratory movement, as well as when those elastic bands, essentially, around each of the alveoli start to degrade and become non-functional, the ribs naturally kind of flay upwards and outwards, which is their natural position when you take a deep breath in, leading to this kind of barrel chest looking person. Diagnosis is primarily based off of history and those clinical manifestations. We may do a chest x-ray to see if they have any bullae formation, or perhaps to see if we have any idea as to how destructive the alveoli have been. Pulmonary function tests, ABGs, ECGs. For treatment and management, it's going to be the same as chronic bronchitis. These patients may have more O2 compared to chronic bronchitis, but it really depends on how they're doing. For these people, weight loss is a serious issue and is ominous for poor prognosis, because if they're having tremendous weight loss, That means they're working that much harder for having to breathe, and they're not recovering from it because they're losing so much weight. They're at a nutritional deficit. So we got to make sure we're focusing on maintaining proper nutrition with these folks. All right, so bronchiectasis, this is going to be dilation of the bronchial wall. So it doesn't look, for example here, which is bronchiectasis, that we have an actual dilation of the wall, but we kind of do, given the idea that all of this mucus is not considered part of the wall. We have destruction of the wall, for example, right here, and it kind of dilates. But we fill it up with all of this gross mucus. This can be either acquired, like with cystic fibrosis, or I'm sorry, congenital, like cystic fibrosis, or acquired, such as with chronic infections and associated with cystic fibrosis, and sometimes can be seen in chronic bronchitis. Sometimes people can get it, but not always with chronic bronchitis. I think I saw at one point it was like 30% of people, maybe 50% of people had bronchiectasis with chronic bronchitis. So we have recurrent infections of the bronchial walls, which leads to this persistent dilation. We also have then bronchial wall thickening. So there's dilation of the walls, but then there's also thickening and an increase in mucus production. The inflammation itself results in the destruction of the walls, and that destructive process leads to a loss of ciliated epithelium, and that ciliated epithelium is what's required for the mucus escalator to work, to get all that junk out of the lungs. These patients are going to have a persistent daily chronic super productive cough because they have so much mucus production going on. The lung tissue itself and the airways are going to be very susceptible to trauma, and they're under so much inflammation that they may have hemoptysis, which is coughing up of blood in the sputum. They may have fever and night sweats from all the inflammation and potential for infection. They may have moist crackles in their lungs from all of that mucus, and that mucus will also potentially lead to halitosis, or bad breath. May have skin pallor, and digital clubbing may come into play here that may show this, but it's not as frequent as we have in COPD. And clubbing itself is due to, so this is due to decreased oxygenation rather than CO2, like I said earlier. So it's prolonged decrease in oxygenation, not in increase in CO2. There's lymphocytic extravasation, so kind of like destruction to the lymphocytes area, and increased vascularity and edema. So a lot of what we're seeing with the clubbing itself is due to fluid accumulation within the distal tips of the fingers. And the severity of this parallels the severity of the disease, regardless, whatever respiratory disease they have that is associated with this. So if they have this advanced clubbing, as we can see here, then we're looking at someone who's got very pronounced lung disease. The treatment for people with bronchiectasis, we're going to be giving them antibiotics when they end up having lung infections, which they're going to have on a regular basis because that extra mucus is a breeding ground for bacteria. We may give them inhaled bronchodilators to help allow for better flow of air through the lungs, and then they may need to have percussion and postural drainage, such as what's going on here, to help allow for and promote that mucus production to flow through down into the airways, or the upper airways, to cough out. We really want to focus on proper hydration to thin out that mucus, and nutrition, because they're going to have a greater work of or effort in breathing, using up more calories. Really cannot smoke, because the more they smoke, the worse they're going to get. We want to encourage regular exercise to strengthen the lungs, and then we want to make sure that they're getting immunizations, especially for children, including the influenza and pneumococcal vaccines. And we may have to do, if it's severe, We may have to do like a bronchoscopy with lavage or surgical removal of certain areas of um, obstructions if there's severe obstructions. So bronchiolitis, this is different than bronchitis because instead of the bigger tubes, the bronchial or bronchi, we're talking about the bronchioles and inflammation of the bronchioles. So this is widespread inflammation of the bronchioles due to some kind of infectious agent or allergic response. RSV is a common cause for bronchiolitis. This occurs primarily in winter or spring, um, and it's pronounced respiratory syncytial virus. And it's the most common cause of bronchiolitis in kids under 2 years old. In adults, we can have smoking or toxic fumes or immunosuppression in general leading to bronchiolitis. So in general, we have the inflammation response and destruction of the bronchiolar epithelium, which promotes then fibrosis and airway narrowing, making it difficult for people to breathe through those bronchioles. We're also going to have goblet cell metaplasia, potentially an increase in, or we're going to have a massive increase in this very thick and tenacious mucus, which increases even further airway obstruction and can promote atelectasis, which is sort of this collapsing of alveolar beds. And they can even then promote hyperinflation from air trapping in the lungs. So just because there's a lot of kids here with this, ICU-looking level of care, um, but bronchiolitis does not always result in such severe manifestations. Sometimes they can be just very mild and self-limiting. Sometimes they can be fatal. We can hear wheezes or crackles or even just a decrease in breath sounds. They're going to be showing severe retractions, especially up towards the clavicles, potentially under the lower margin of the rib cage. We're going to see a tremendous increase in sputum production. We're going to see dyspnea and tachypnea, potentially have then also a low-grade fever. We're going to diagnose bronchiolitis based on having an increase in white blood cell count. We're going to do a chest x-ray to rule out other issues like potentially pneumonia, and do a nasal swab to diagnose specifically RSV. Treatment is going to include oxygen to try to promote more oxygenation and less or a greater saturation. We're going to give them bronchodilator to try to open up those bronchioles as much as we can. They're going to be super inflamed, so we're going to try to give them corticosteroids to reduce inflammation. We may sedate them a little bit for anxiety because these kids are going to be super anxious and trying to breathe as a natural response. We're going to give them lots of fluid to thin out that thick, tenacious mucus production. If there's a bacterial infection, we may give them antimicrobials as well. We're going to make sure that for kids, they're probably not on, a 2-pack per day smoking plan, but they may be around secondhand smoke a lot. And so we really, really, really need to educate parents on you can't not only not smoke, you need to make sure you're not around your kid afterwards when your stuff smells like smoke. If your house smells like smoke, your kid can't be in there until you fix it. If you and your clothes smell like smoke, you got to find some way to smoke if you need to smoke and not let your kid be exposed to that secondhand smoke. And then if they have RSV, then we're going to wear eye and nose covering to prevent transmission or getting. I'm actually not sure what that's about. I think maybe that's for us. I don't know. Cystic fibrosis. This is a autosomal recessive disorder of the exocrine glands. I think you guys may have covered this in Cron 1. The big thing here with cystic fibrosis is we're talking about a disorder of the exocrine glands where we have this massive production of mucus, which blocks all sorts of stuff. It is the most common genetic lung disease in the U.S. And affects a whole bunch of stuff within the body. Most people, unfortunately, only survive until 31 years old. So what is going on here is we have a problem with the cystic fibrosis transmembrane conductance regulator, which is this little doohickey right here, the CFTR channel. Normally, they're supposed to be able to easily pump out chloride ions, which I believe are used to help thin out mucus and not allow it to really build up the way that it does in cystic fibrosis. Instead, there is a mutation to it because of the recessive disorder, and we end up not getting the calcium ions out here to thin out the mucus. So the mucus ends up becoming super sticky, super thick, and very difficult to get out. It affects a whole host of areas in the body, including the pancreas, since the pancreas is our main exocrine gland, the intestines, the sweat glands, the lungs. We get these huge amounts of buildup in the lungs, preventing oxygenation or ventilation. And then the ductus, the vas deferens, ends up having a difficulty in, I think, 90% of people in developing, leading to male infertility. They're still producing sperm, but their semen can't get to the sperm. I'm sorry, the sperm can't get to the semen and actually allow for reproduction. The glands inside the GI tract then also enlarge and produce a whole tremendous amount of mucus. And all of that extra mucus leads to obstruction, atelectasis, hyperinflation due to air trapping, a decrease in ciliary action because those cilia are just trapped in this thick mucus and can't move around, and they are at super, super, super high risk of infections. So clinical manifestations for this is we have this very, very strong cough with thick, tenacious sputum. You stay on. Recurrent pulmonary infections and bronchitis, which is more often than not one of the main reasons they end up dying young. Dyspnea and tachypnea, sternal retractions because they're having to work so hard to breathe past all of these obstructions. Their lungs are going to sound horrible because they have so much in there that causes turbulent airflow and obstruction. They may end up with a barrel chest that is very hyper resonant. So if you do percussion on a patient, they're going to sound like a drum because their chest has so much air trapping in there. It's going to just resonate. And then later on in their prognosis, they're going to have potentially digital clubbing. So they're also going to have pancreatic insufficiency because they're going to have blockages of the pancreatic enzymes out of the pancreas, leading to an inability for them to actually digest their foods properly on their own. They may have a cirrhosis of the liver, diabetes mellitus because they're not getting adequate insulin excretion, which is it's an endocrine gland, but it can be affected by these blockages. They have gallstones, nasal polyps, failure of development of the vas deferens in males leading to reproductive infertility. The big things for them are they're going to have nutritional deficiencies because of that pancreatic insufficiency, and they're going to have an increase in their work of breathing because they're having to work. They're going to have so many blockages. They're going to become anorexic and have a reduction in the growth rate because they simply don't have access via their lack of pancreatic enzymes, access to all the nutrients they get. They actually have to have double the volume of calories just to try to get enough in their system. And even then, most of it's going to end up just going straight to the toilet. The diagnosis is going to be via a sweat test and genetic testing. I don't remember, I think the sweat test is for testing for chloride in the sweat. I can't remember exactly. Treatment, we're looking at aggressive treatment of respiratory infections because any infection they have are very high risk of developing into super serious infections. We're going to be doing postural drainage and chest physiotherapy, which is what we're seeing right here. Trying to knock loose a lot of that mucus production so that they can cough it up. They're going to be working on forced expiratory techniques to try to cough up that stuff even better. We're going to be using medications to try to promote better breathing, or in this case, try to avoid a lot of the infections that we can get or that they can get because they have cystic fibrosis. We're going to be promoting good nutrition to try to ensure they have enough calories. And then we're going to be supplementing them with pancreatic enzymes to give them access to the food that they get. They may have to eventually get a heart or lung transplant. Heart because they have to work so much harder to get blood through those congested lungs, and then they develop right-sided heart failure. And for the lungs, their lungs are just awful. So they may end up just eventually getting a lung transplant, which may improve their lifespan. For croup syndrome, this is a pretty common childhood illness. It can be due to a viral or bacterial inflammation or infection that develops inflammation in the larynx or voice box area of their airway. This is already a very narrow area of a child's airway. And croup syndrome can occur in generally fall or early winter and affects most often children who are 6 months to 3 years of age. So we have some form of infection that leads to inflammation along this thin airway or thin portion of the airway. We develop then edema subglottically in that airway. Some manifestations, their history may show that they have a history of upper respiratory infections previously, which just indicates that they're more susceptible to it. This barking cough with stridor is going to be kind of a classic sign of croup syndrome. It may sound similar to like a whooping cough, but it's hard to say. You have to look it up on YouTube, and they have some great videos. And then they're also going to have stridor. One thing to make sure you're aware of is that they will not have drooling the way that they will with epiglottitis. So epiglottitis, and I think that's misspelled. Epiglottitis is going to be inflammation and swelling of the little flap, the epiglottis area of the throat. That's a much more significant issue compared to croup. A lot of times you take a kid who's got croup, which occurs during the fall or winter typically, outside to what normally is a more humid environment. It's a colder environment. That tends to help resolve some of those symptoms. And then you keep on doing that and they get better. Sometimes we got to treat them with other things, such as corticosteroids. Maybe needing to give them nebulized epinephrine, which will stimulate the sympathetic nervous system and allow for airway opening. But a lot of times, mist and O2 therapy are all kids need to alleviate a lot of the more crisis-style symptoms. For kids who are looking like they're going into respiratory failure, we may have to intubate them and control their ventilations, and then give them medications. And then some kids are just working so hard and have so much anxiety from having to work that hard that we may need to sedate them, which we obviously would if they were intubated. But we may have to sedate them to help to calm them down and prevent more SNS activation and stress hormones.